Hello, everybody, and welcome to another SimiTree Healthcare Consulting webinar. This is actually the first SimiTree Healthcare webinar. I'm very excited to announce that the former Black Tree has merged with the former Simeon Healthcare Consultants to now form SimiTree Healthcare Consulting. So I'm very excited to have our first SimiTree Healthcare Consulting webinar here. Joined by my new colleague, Laura Wilson. I also have a couple of old friends with our friends from Evergreen Home Care out in Washington State with Brent Cordy and also Molly McDonald. And we're going to talk today about avoiding LUPA holes. So some strategies and tips for how you can better manage LUPAs. I think this is still a very popular topic, probably one of the more challenging aspects of PDGM. So we thought it would be a good idea to have a topic to really discuss this in more detail. So a couple of housekeeping pieces before we get started. There are no handouts for this webinar today. This is going to be more of a panel discussion, a lot of discussion topics. You will have a handout, though, that goes tomorrow to anyone who attends, essentially a one-page recap highlighting a lot of the key points that we are going to discuss during the webinar, and also going over our poll results. So that's going to be one of the other housekeeping items throughout our session today. We're going to have a few polls. Please respond to those polls. It usually is very eye-opening, some of the insight that we get from those polls to see, where everyone's head's at in terms of some of the different topics that we have within the polls. Regarding any questions, we're going to try to save some time here at the end for some Q&A. But throughout the session, if you do have some questions, there's a Q&A section on the right-hand side of your screen, or there's a chat section. Feel free to enter your information there. So I'm going to do some quick intros, and then I'll get into a little bit more about why we're doing the session today. So we'll go with ladies first. I'll start with my new colleague, Laura Wilson, if you want to give your intro.
Thank you so much, Nick. And what an exciting time it is. Being part of SimiTree. So I am the Managing Director of Operations Consulting. I am a registered nurse by background. I have over 30 years, and that's as far as I'm counting. I'm stopping at 30 years of experience in the home health and hospice area. Big ones, little ones, national ones, you name it. And I actually lived out in Seattle, where my new friends Molly and Brent are from. So thank you. Glad to be with you today.
Thanks, Laura. Over to you, Molly.
Hi. So thanks for having me. I'm Molly McDonald. I am a PT by trade. I work as the program manager here for at Evergreen Health for quality and kind of regulatory compliance. So a little bit of everything is kind of what that role entails. And I've been with Evergreen just over 10 years, and I'm super happy to be here.
Great. Thanks, Molly. And last but not least, Mr. Brent.
Hi, everyone. Brent Corty, Chief Home Care Officer at Evergreen Health. We're Seattle, Washington area based home health and hospice. We are about 1,500 home health patients presently, plus a hospice contingent of about 500 patients. But I think, like I always like to say when presenting with Nick and Molly and Laura in the future, that we have experience working with all different sizes of home health and system-based, not system-based, et cetera. So hopefully we can provide a lot of detail related to that. And I'm excited to be part of the first SimiTree webinar. Thanks.
Great. Thanks. Well, appreciate you all being here. Like I said, I think this is a very topical discussion point here. I know we had a story that our friends from Home Healthcare News had ran last month on LUPA challenges, in which there was some insight from both myself and from Brent and Molly. So thought it would be a good follow-up based on that article, and again based on some of the discussions and some of the data points. We've been doing a lot of analysis specifically on LUPAs. I know there's a work group at NOC that's been really taking a deeper dive into some of the LUPA numbers, especially with the behavior adjustment we know that was built into last year. And based on where Medicare thought we would be and where we are today, they're two different things. Just for a little bit of background on that as well, I think we had two main impacts from last year that really have impacted our LUPA operations, I should say. number one, we had PDGM. We have a change from the payment system from PPS to PDGM, and that really changed how we look at LUPAs and how we manage LUPAs in this new world. Going from that one threshold of 5 visits over 60 days to now 432 unique thresholds based on what your HIPS code is, and cutting that time period in half from 60 days down to 30 days has really made it challenging. And I think it's still an area that agencies are struggling with. So we really want to take the time, the next 50 minutes to discuss some of those strategies for how to manage those LUPAs. If you're looking at some of those numbers and percentages, back in 2019, if you look at what the final rule was published by NOC, leading up to PDGM, they were looking at a LUPA percentage of about 7.1%. Again, based on the behavior adjustment, they thought we were going to get better at this, that number was going to go down. If you look at where we actually ended up in 2020 for the year, right around 9%, 8.9% is our LUPA rate. And those, that's going to be a big determining factor in what your revenue is. If you look at the difference in reimbursement between those, your average period payment of about $1,900 compared to your average LUPA payment of about $300, you're looking at a $1,600 spread between those two numbers. So obviously it's a big impact on revenue. So, something that we really want to focus in on, as we know that from a budgeting standpoint, it's definitely one of those huge drivers. So Brent, you're back with us for the first SimiTree webinar. You were actually with us for the first BlackTree webinar last year, when we were discussing all things COVID. That was when we were knee deep in the pandemic, and you, of course, were one of the first folks that were really impacted the most out there in Washington State. So I know we've had a lot of discussions about the pandemic. If we're tying this into LUPAs, why don't you talk to us a little bit about how COVID really has impacted LUPAs for your agency?
Yeah. Okay. Yeah. Thanks, Nick. Great question. So if you've seen a presentation about what Evergreen has been through early on the pandemic, and what we've all been through as a nation and as home health providers, then I'll do my best to not completely recap that. But it's hard to tell the story of LUPAs without telling the story of the pandemic itself. So bottom line, the pandemic fundamentally changed the delivery of home health and hospice in our country. I think we all probably have felt that, if nothing else, at its very simplest, we're on the map. And it's super exciting to be on the map, but now there's an added amount of scrutiny that comes with it, and certainly higher expectations, and I'll speak to that. One of the downsides is there was the increase in patient acuity. A lot of folks liken the fact that a skilled nursing facility is now in someone's home, effectively. When America became homebound, home health and hospice and home care stepped up and met the moment. So for us, that moment was the 29th of February, 2020. Now, PDGM started almost exactly 60 days before that. So when the pandemic started, we essentially had to look at the exact same rules applying, but knowing that we're progressing in a very different environment. And so the way we view it is that what are variables that changed? What are variables that didn't change? So the same variables were very simply, LUPA classifications didn't change. We knew that because of the pandemic, for the most part, there weren't any vast changes. We were playing with the same rules for the most part. But multiple factors changed in the pandemic. For instance, control over visits. I imagine that many of us that have been through the pandemic didn't feel like we had the same level of control. So factors that impacted that were us protecting our clinicians, lack of access in the home setting and congregate settings in particular, and then PPE nuances. The next more significant variable that was part of the pandemic was just general disarray. I mean, we look back and you think about what we all went through in the moment that the pandemic hit your community. Now, in retrospect, it actually seems like we did okay. I imagine everyone feels that way. But in the moment, man, we were working the problem, and then the next problem comes, and we work the problem. And it was difficult to make sure that that LUPAs and PDGM were front and center. However, that was critical in doing so. So I think you probably heard me say this before if you've attended a previous SimiTree Blacktree webinar. That we had 3 goals: keep staff safe, continue providing care, and keep our business going. And keep your business going really doesn't just mean keep your business going. It means keep your people employed. If you think back to 15 months ago, that was we didn't know exactly what was going to happen with the economy. And then the third variable is that we found a steep and linear. Going to go back to statistics class here, but a steep and linear correlation between the severity of the pandemic and the severity of our patients' sickness. The further the pandemic got, the sicker our patients got, and the more of them that we had. And that taxed the concept of LUPAs significantly. How many visits are we supposed to provide to these folks, and how can we do so in a way that is right by the patient? And then finally, for us, we experienced a 35% increase in our census from November 2020 and for the year following that. So the impact on LUPAs was significant. A couple more timeline stops here. Elective surgeries stop in March, and we had a huge excess of therapy. And then all of a sudden, our nurses are overwhelmed. Well, lo and behold, in May, they start back again. And we went from famine to feast and had significant labor issues. And that caused a ton of pressure on LUPAs as well. If I have all of a sudden 2 patients on my caseload and I go to 50, how on earth are you supposed to get to that minimum LUPA amount? And we also can't deny the fact that we have a minimum amount and then we have a maximum amount. I mean, in theory, if we go over too many visits, then it becomes a loss from a financial perspective. So the way we view LUPAs are essentially like a goalpost. And we were really working hard to try to get in there. And then finally, I think it's important to admit that the pandemic may have helped with visit efficiency in some cases as access was limited. Now, it's hard to admit that, but it seems true to me that if we were only able to get into an adult family home in Washington that's a congregate setting with 6 or fewer people, or an assisted living facility, we could only get in 5 times and the LUPA was 5. Well, that perhaps could have favored it. That's not how we wanted to do it because we didn't have control. So significant effects, very, very dynamic environment. And again, I would be remiss to say that without folks like Molly and our excellent clinicians and managers, we wouldn't have gotten through in the way that we did. And I imagine everyone listening would echo the same sentiment with their teams.
Great. Appreciate that, Brent. Yeah, I think, some of the themes that you talked about and even looking at the overall impact of COVID on LUPAs, I think as we're going to get into some of the data a little bit later on, just in some of the trends that we've seen with LUPA percentages pre and post pandemic, I think some of those numbers are really telling in terms of, it's not necessarily improving as much as we would have thought. So I think that leads to, one of the main questions that we really want to talk about is how do you manage LUPAs? What are some of the best practices and best ways to manage them? Molly, why don't you start a little bit with how you handle them specifically at Evergreen, and then Laura, will go to you just to talk a little bit more about what you see nationally.
Great, thanks. Yeah. So at Evergreen, we kind of focus when we talk about managing our LUPAs, we focus on a few things, but it kind of comes down to for us, education, visibility. And by visibility, we mean getting numbers in front of people so they can plan and move forward with those numbers. We talk a lot about coordination and transparency. And when we talk about transparency, we mean feedback. So the data, kind of bringing it all together and kind of seeing what that was. And at Evergreen, that all starts with us. And is really centered around our pods and our pod meetings. So I think I'll talk a little bit about pods and kind of how we wrap a few things in there of these 4 things. So pods that we here, we have big geographic teams. And so pods are essentially just tiny IDTs within those teams. So we have multiple pods per team here at Evergreen. And we had these before PDGM, before pandemic, before all that, but we've really, really focused on those, especially with LUPAs last year and this year. So these pods, they meet weekly. And they've been virtual since the pandemic. And, I think people loved getting together and they loved seeing their colleagues, but this has really been helpful with our pod meetings. It's really increased efficiency, and it's allowed some of those clinicians who maybe have patients in multiple pods to be part of these conversations every week, and they don't have to pick and choose which ones to go to. And that goes for our clinical managers as well. They love it. They can pop in for 10 minutes, discuss patients, do some of the data, and then get to all of them, as opposed to, again, having to choose which ones to go to. So in these pod meetings, the discussions, obviously there's some variability, but really we ask them to talk about, numbers and utilization. So they're talking about thresholds, they're talking about dates, they're talking about what visits have been done, so kind of our visit counts. And if they don't have what they need, they're supposed to reach out. If something's not calculating right or they need it, they reach out to our managers or a business analyst, which I think Brent's going to talk about a little bit later. And then on top of that, or layered either way you want, they start talking about the clinical coordination and the clinical needs. So what needs have to happen? What visits have to be done coming up? Are you going this week? I'm going next week. Can I do that for you on my visit next week? And you can phone call. So all of that's kind of going on during these pod meetings every week. And then DC planning, of course, is in there as well. So they're working on that. So when we talk about the education part of these, we do a lot of education in pods because it's a really actionable route to do it. And of course, there's the what is LUPA, what are the thresholds, all that education. But we've really focused on their impact. What is my impact? I know it, but what am I doing? How can I do that? So we constantly throw out scenarios. And our education is just around, you move a visit here, you do this, and numbers up and down. That's what happens here. So scenarios are really where we're focusing on utilization and distribution of these visits. And when you talk about visibility, some strategies we've done there is really kind of working on getting our timeliness documentation down. So we can get that visit calculated or locked, whatever the terminology is, to get those numbers in front of the people who have to use the numbers and really do that. Our coders and our QA team have done a ton of work, and our clinicians working out the timing of this. And what came out of it for us is we now have weekend coding and weekend QA work. So it kind of keeps the rhythm up. And so there's not this log, and then, after the delay of the weekend, then people log in. So that has been really helpful. Other thing we have is called a LUPA in progress report. And so the managers are getting this report, and with 10 days left in the billing period, if you haven't met your LUPA threshold, that manager's reaching out to you and you're going to chat about it and see why not, the plan, sometimes it happens, those types of things. And then just to talk really quick, a little bit more about coordination. So the actual coordinating is happening in these pod meetings, and it's really going, and the clinicians are doing it. But what we've really worked hard at doing, and we're continuing to do that, is support the clinicians, giving them this form, kind of this forum or the format to do this coordination, making sure we're making these pod meetings efficient and streamlining and standardizing the templates. And then really what we're doing now is looking at our productivity model and looking to see, in the changing world and how much increased coordination, is it really meeting our needs and the clinician needs and our business needs? So really re-looking at all of that.
Great. Appreciate all that insight there, Molly. Laura, what have you seen nationally? A lot of our clients and whatnot. What are some things that you're seeing some of those clients do well? You're on mute, Laura. We're gonna unmute you real quick. Hold on. There we go.
There we go. And we're going to put Molly as the poster child because she gave you some really great information there. I see one of the questions coming in here too of what are the pods. Pods in other terms might be your team. It's a larger group. So it's not just the case manager. It might be a number of case managers that are working in a certain geographic. Am I correct, Molly? Does that sound fairly what it is? It's your IDT meeting, your interdisciplinary team meeting. And I have said since I started in home health back in the 1900s that IDT is where the magic happens. And it really is the opportunity to really truly meet the needs or the requirements and the conditions of participation and actually talk about things. So LUPAs are just something, as Nick's colleague, Rob Simeone, who is another one of the principals, said, is really the low-hanging fruit of reimbursement and care that we're delivering. This is something that if you just put it top of mind and really focus on it, like Molly was saying, having a weekly report, looking at it 2 or 3 times a week, when you're in your teams or your pod doing your interdisciplinary team meeting, you don't need to go through every patient, but do make sure you're going through your new admissions and that you have a plan, that you know what's going to happen. Your complex cases, your high risk, that you're looking at research. Remember, we're still in a 60-day episode, but our LUPAs are being calculated in our 30-day periods right now. So that's going to change. You don't have 60 days anymore to fix any problem, any missed visits you might have had, or the patient refusing a visit or pushing things out. You've got to keep that into that 30-day visit. Be aware of what disciplines you've got in there, and communication is the name of the game. So if your DC, if you're one discipline that's in there and you're discharging, but the physical therapist is staying in and there's still a home health aide, that PT needs to keep in mind that there's a home health aide trailing along behind them as well. So you don't slip that one home health aide visit into the next period and you're in a LUPA situation. So it really does come down to exactly what Molly said, is you need to focus on it. You need to know your thresholds, bring them up, and you need to be reporting on them very, very consistently.
Great. That leads us to our first poll question. So that's going to be, we're going to start this poll, is how often do you discuss your potential LUPAs during case conference? Is it weekly? Is it more than weekly? Or is it less often than weekly? And then real quick, going back to you, Molly, just a question that popped up in the chat was who runs the pod? How long are the meetings? Do clinicians go through all their patients during the pod meetings each week, or is it only a select number?
So the pod is run, and it's just what Laura said. It's a little mini IDT. So there's the case manager and one of almost every discipline in there. The pods run about an hour to an hour and a half, depending on what we're doing. And the person who leads it is, I don't want to say it's always the case manager. The pod kind of decides who's going to kind of run this. And we have a couple different ways. Some pods say, hey, you're going to do the timing, so make sure we're keeping on time. You're going to monitor our list. This is the people we're going to talk about. And so they kind of mix it up. Some, it's the same person all the time. So we leave it up to the pod and how they want to run that. And then was there a third part I missed?
Are you talking about all the patients, or is it, just so how are you selecting those?
Yeah. So in that one, that's a hard one. So we've gone through a couple different things. We do not talk about every patient every week. And so we definitely talk about new patients coming on. If it's a single discipline, it likely doesn't get talked about very much in that format, unless we're having a clinical issue, because there's that part too, where that's your support team and they're going to help you through those types of things, or if we need a referral and things like that. So that comes in there. And we're just really working on standardizing that and holding people, which is another great reason why we can have the managers pop in and out to really help work through some of those challenges with standardization.
Great. Appreciate that, Molly. We talked, I know, Laura, you just mentioned again, the 60 versus 30. I think that's, another huge challenge when it comes to managing LUPAs, is it's based on those 30 days. And especially if you go back to looking at the start of care for that first period, how do you determine what your LUPA threshold is? It's based on your HIPS code. And you're not going to necessarily have that HIPS code on day one. We know we need to go out and see the patient. We complete the OASIS. There's the QA process where it's going back to QA. You're having feedback, interaction with the clinician. You might be gathering additional information from your referral source to complete that coding. There's a lot of back and forth that's going to be taking place before you actually lock that OASIS and have that final HIPS code that's going to determine what that LUPA threshold is. So, I guess one question I would have for you, Molly, is how quickly after the start of care do you know what your LUPA threshold is? One other side I'll put to that is that we no longer need that locked OASIS to submit the RAP. So we've been hearing rumblings of some agencies where that process is taking even longer now, knowing that there's not as much a sense of urgency with that 5-day window. We can just bill it with a generic HIPS code rather than having that real one. But we do know how important it is just from a LUPA management standpoint. So Molly, again, the question over to you: how quickly after that start of care are you locked? Do you know that your LUPA threshold?
Yeah, and I think, when we talked last week, Nick, the short answer is just not quick enough. It just isn't quick enough. And we are constantly working on the timing of that. And it's been honestly one of our biggest challenges is getting this number up in front of people and getting it timely and getting it correct. To be honest with you, we've had a few challenges with that. It kind of goes back to the coordination and the communication piece. So we really try to emphasize, we realize you're not going to have that number day one a lot of times. But that does not, you're not going to go wrong with starting that hit the road running coordinating and get going what that patient needs and figuring that up front, because we are going to get the numbers to you, within a few days. We have a couple of instances like with our record, if the visit just isn't locked yet, they don't stamp the LUPA thresholds on there, but they have a HIPS code. So we have the CMS spreadsheets. If there's a HIPS code, give it to us and we'll help the clinicians put that on there so it's in their mindset, things like that. But really just emphasizing kind of our core LUPA strategy and getting that going, and then we'll get the numbers as fast as we can.
Great. Laura, what are you seeing nationally with that? Are we seeing quicker? Is it faster, longer for getting that number?
People, like you said, Nick, we have seen a little slow down in getting that OASIS, because you don't have to lock that OASIS. You don't have to get it in now prior to dropping that wrap. People eased off on that gas pedal. And for a myriad of reasons, you still need to stay strong in that 5 to 7 days as best practice, getting that OASIS, everything in, truly knowing what your HIPS code is. We are seeing occasionally some folks are doing almost a pre-coding, taking I've got a diagnosis, I can do a little guess on this. I can have at least a shot at where I think my threshold is. I've not seen that anywhere be highly successful yet. You're better with sticking to your process and making sure that you can move things through expediently. And oftentimes what we're finding now is that means that you need to, much as Molly said, you need to consider how you can process if you're a larger organization, even on the weekend. Things still have to move on Saturday and Sunday. You can't afford that 2-day drop in there. The cheater way, worst case worse, I would just assume at least 4 is your threshold, and you're pretty sure you're going to get over most things. Then if you're not going to get your process in shape, but it really does need to have that assessment OASIS in QA'd, ready to go for a lot of reasons. It makes your on-call easier because people have access to things, as well as getting that LUPA threshold number. And then not just getting it, but actually telling people what it is, letting people know. So it isn't just oh gosh, now we know that it's 3. Does who's ever doing scheduling know? Does the case manager know? Does the team know that's on that patient that this is the LUPA threshold? How are you communicating that? Great.
Makes sense. Talking about numbers, one of my favorite things, numbers. I'm a big data geek. Data is king, and we know that famous quote: "If you can't measure it, you can't manage it." With that being said, a couple interesting data points that I was looking at when we were looking, kind of looking at some of the numbers from this presentation. We already talked about, the overall LUPA rate for 2020 nationally was about 8.9%. That number has continued to increase. If I connected with Chris Ataya from SHP earlier this week just to get a better sense for what SHP's number for Q1 of this year is, and it's 9.1%. So again, that number has remained steady. Probably the most eye-opening stat that I saw regarding LUPA data was this one. In terms of if you look at the overall percentage, if you just look at that segment that missed the LUPA threshold by one visit, the percentage of LUPAs is over 60% of LUPAs would have been full periods if they would have just had that one visit. And like I said before, that's about a $1,600 difference in reimbursement. So, talking about data and looking at numbers, Molly and Brent, I'll have this one over to you all in terms of a two-part question here. Number one, what data are you using to manage LUPAs? And then number two, how often are you looking at the data?
So I can start off with that. So this kind of rolls back into what we first talked about. This is the transparency part where we're really trying to do data and feedback. And again, at Evergreen, we rely really heavily on our pods and our pod meetings. So we have what we call a pod scorecard here. And part of that scorecard with LUPAs is, and this is, we give it to them monthly, but we also have year-to-date info on there, and we do pod level, so what their pod's doing, but we also give them the agency for kind of a perspective and getting that sample size in there. So we really break the LUPAs down when we talk about what data are we looking at. We do the billing periods, of course, so we do first, second, and then we do third or later. We also, on top of it, we talk about overall utilization in there, and we're starting to talk more and more about length of stay. That's not a metric we really focused on a lot pre all of everything, but we're now seeing some changes where we were really steady there for a long time. So we're starting to look at that. So that data goes to them on a monthly basis, and the clinical managers actually bring that to the pods. And they're really great at doing that. You know, they look at the trends and help the pod really work through some of those. So some of those numbers, when we talked, did we miss it by one? And they really look at, is it a referral source? Is it a timeliness of care issue? Is it, you know, Brent talked about our increased census and our staffing. Is it, you know, we can't quite get a continuity of care up front, so we can't get our coordination going until, you know, 20 days in? Is it that kind of thing? So the managers are really helping that, and then taking that info and then going and saying, you know, we need more staff, or we need, you know, a different kind of makeup of staff down there. We need more nurses, we need more PTs, that type of thing. So that's really where we've been getting the LUPA information and talking through it with clinicians monthly.
Great. Brent, anything to add there?
Yeah, thanks. There's some really good questions coming in. I'll do my best to try to address some of them as we go through. So one of the concepts I've heard a bit about is just the concept of dollars left on the table. So to address your question, Nick, what data are we using to manage LUPAs, and then how often are we looking at the data? I also want to maybe throw in a third question, which is how are we communicating it? So back to dollars on the table quickly. The sense of latency of financial reporting early in the pandemic really sort of caused us, it pushed us back to the fundamentals. So what I mean by data latency or financial reporting latency is, if we think about it, January 1st, PDGM starts. For us in Kirkland, we had the first, we know of, one of the first home health patients on our census, the first hospice death in the United States, and the first death in a hospital with our health system. And that happened almost exactly 2 billing periods to the day from when PDGM started, which is when we thought all along we were going to start having clean financial data, essentially the day after Leap Day on March 1st. So we were flying blind. We had, you know, the PPS was essentially sussed out through the end of February, and our March financials we were hoping would be our first lighthouse. We didn't have that. So really it forced us to get back to the fundamentals. So the concept of understanding data, in particular from a financial perspective. I don't know how many financial leaders we have on the phones, or on the webinar, but I imagine that we all felt very helpless on those early days, knowing that, you know, we may have some concept of how we're doing with LUPAs, we may have some concept of how we're doing with visits, but we're also trying to procure PPE. We're also trying to talk our way into every manner of congregate setting. So that latency of data was super difficult. And then again, that third question that I went ahead and took the liberty of adding, Nick, about communicating the data, really goes back to the pod structure. The pod structure was designed to say that, okay, so we have a certain amount of data that we're using, number one. Number two, how often are we looking at the data? But three, how are we actually communicating it, and how are we giving folks a moment to make choices? So our pod structure was that communication method. And here's a silver lining, one of the silver linings of the pandemic, that we were forced onto virtual platforms. For Evergreen Health, we use MS Teams. And Microsoft Teams is super efficient. The pods literally what felt like overnight adopted Microsoft Teams, and it made pod meetings a little different. Where listen, we don't know how. One of our pods meets at a dim sum place in downtown Seattle, so that must be exciting for them. However, you got to get in your car, you got to go through down I-5 and worry about traffic and worry about parking and the ID and all this stuff. It actually made it quite easy because we were able to get together succinctly and say, hey, right now we've got all 6 of us. Here we are. Let's work through these patients. And it probably helped productivity. It was also quite interesting, again, just to address some of these questions about standard work and pods. We did give and probably continue to give some amount of levity during the pod meeting to ensure that our folks do have a human moment together. I think we've heard many CEOs talking about the idea that we have to find a way to support our folks after the pandemic. One way to do so is to manage LUPAs, so they're employed. Another way to do so is to help make sure that they feel supported after what could be one of the most difficult periods in their clinical careers. So we did allow that time during pods. That said, we're also hawks on standard work, and we really, really try to make sure to listen. You said you were going to go through 17 patients. You got to go through those 17 patients, and then you need some time to catch up, then do so. Lastly, there was a question about productivity in pods. It's not counted in our productivity measurement. However, we have found across the board that our productivity has improved by virtue of better care coordination. So there's less superfluous visits, more purposeful visits, and in general productivity. There's also sort of an expectation among let's pretend the 4 of us were all on a pod together, and Nick, as he often tries to do, calls me out. Nick's a PT. I'm a speech therapist, and he said, Brent, you're supposed to be out there last Tuesday, and that would probably be a good motivator for me to do so and make sure that we kind of stick to our care plan. So.
Great. Appreciate that insight there. Molly, you talked about reasons for LUPAs. I'm going to ask a question first, and then I'm going to start a poll. Really around some of those common reasons. We know that there are certain LUPAs that are not going to be preventable, right? You're going to have your cath changes that are going to be 1 visit a month, and guess what? That's going to be under the LUPA threshold. So there's going to be some that are absolutely preventable. But let's talk about some of the other common reasons for how you can prevent some of those LUPAs. Before we go into that question, I did want to have another poll here on what your LUPA percentage is. Is it less than 10%, between 10 and 20%, or more than 20%? So if we take the time to answer that poll question, and then Molly, if you want to lead us off with some of those common reasons and some tips on how to prevent.
Sure. And I just wanted to add one thing about our productivity. We do have some case management time that we're kind of looking at building into the day that would kind of help with some of that. So that's really where we're looking at that. But as far as LUPA reasons, what we're seeing, obviously some of the real obvious ones, the patient refusals or preference, where they want you to come at a certain time and that puts you over into the next billing period. And kind of on the flip side, the same, we see those with clinician schedules. We have staff with varied FTEs. And if we're not really proactively looking ahead, if someone doesn't work Thursday and Friday and, I'll just go DC that patient next week, that's a problem. So we were working through that as well. And again, really relying on the pods to look ahead to try to avoid that and see if we can either get the visit in or have someone else do the visit during that time frame. And also, we've had quite a few observation stays in the hospital, and those are tricky for us because it's a little bit more coordination, trying to track people down and then are they resuming, are they not, and scheduling. So that's kind of thrown in the mix as well, which has kind of gotten to us a little bit. And then just kind of back when we say reasons for LUPAs, I think we see a lot of kind of the higher the caseloads go, the less proactively we can coordinate. And so we've seen that as kind of happening a little bit. So we're trying to work on that. As far as what we're doing, it's, we've said it 100 times already, I think, but the communication and coordination on all levels. So if caseloads are going too high, we need to hear about it. We need to hear about that up front. We need the clinicians to coordinate with each other and with us. And if they don't have what they're needing, they need, get it back to us, and we can either get it to them or work on a process that we can get to them. And the other thing we're really working hard on is the early continuity of care. So getting that case management team set up and in. in the first couple days, get the team out there, met, and go from there. So there's not an increased level of coordination that's happening on top of all of that.
Great. Laura, anything to add of what you're seeing as well?
Well, I'm going to add one thing too that Molly talked about last week, which is in defining what reasons there are. Molly was getting pushback from her staff when saying it was a clinical versus a non-clinical reason, and switched it. Did I have this correct, Molly? Switched it to switched it clinical to non-clinical from preventable versus not preventable reasons, so that you're trying to track what are the reasons that you're running into LUPAs. It's some of the easy ones, like you said, you move a visit one day and you move from period 1 to period 2 by moving from Wednesday to Thursday because that was the date that the period moved. Well, like I said, we've only got 30 days. You've got to keep an eye on when that 30-day cut is going to come. I see somebody asking what's the best way when people are refusing visits. It starts with, we're finding the folks across the country that are most successful. It really starts with that admission visit, in really having a conversation with this patient and their caregivers that this is important. This care is important, and we're committing making visits to you. We're committing, we're developing this plan together. I'm going to ask that you commit to me and to what your physician is ordering for you, so that there is almost a verbal contract, letting them understand just how important all of this is. The old fallback, and it still works because we're still at the kind of the tail end of that greater generation, and now some of the baby boomers, is, well, your doctor really wanted you to have this. This is really important to your plan of care. Doctors' words still carry weight, and make use of them where you need to. The last is, if you've got somebody watching scheduling, sometimes when you're going fast out there in the field with your clinicians, like Molly and Brent are talking about with their pods and with the teams, it can be hard to keep track of, has everybody made their visits? Did all the PTs make the visits that I thought they were going to make? Did the home health aide get in there and get started? This is where scheduling really needs to be your air traffic controller, your watchdog on what's going on, and actually meaningfully looking on a daily basis. And when they're asked to move a visit, understanding what a LUPA is and what moving that visit can mean, what it can throw you into. So it's was an old axiom, what you focus on expands. So if you're paying attention to it, you'll see it, you'll know it, and people will understand it.
Great. Thanks, Laura. Shifting gears here, going back to the behavior adjustment, we mentioned that at the top of the webinar. Definitely another popular topic. We had the proposed rule that should be coming out here in a couple of weeks. A lot of the questions revolved around that are, how are we going to, is Medicare going to look at the data, and is there going to be another adjustment built into next year's rule? Looking at the numbers, again, we go back to the data that Medicare had, that they published in the rule, showed a LUPA percentage of about 7.1% based on the 2019 data. If you look at the behavior adjustment that ended up being factored in to the specific component of LUPA behavior change, which they're expecting about a third of LUPAs within 1 to 2 visits actually now hitting the threshold because of our behavior change, that would have driven the LUPA percentage that CMS was expecting in 2020 to about 5%. Now, we know that we were at 8.9%, as I mentioned before. Even looking from quarter to quarter, we broke it down and said, all right, let's say Q2 is really that quarter that was probably the most impacted by the pandemic. Brent, for you all, is probably more Q1, but going from quarter to quarter, Q1 was 10.1%, Q2 was 8.9%, and let's assume that Q3 is kind of when we started to get into that more, the new normal, quote unquote, the numbers dropped down to 8.4%, but then in Q4 we saw an uptick back up to 8.8%. And as I mentioned earlier, from the data we saw from SHP, it's about 9.1% in Q1 of this year. So I guess one of my questions specific to the behavior adjustment, and Brent, I'll throw this question to you, is how much of that LUPA percentage being so much higher than what Medicare expected do you think is as a result of the pandemic, versus how much do you think is it a result of just the challenge of managing LUPAs under PDGM compared to PPS?
Okay, great question. So I think to best explain my my reply, and I dare I say opinion, I may get a little editorial here. It is to go back through one more time through the experience. So it's for us, it's not as simple as assuming that it decreased or increased LUPAs. It's a super dynamic environment. We all know there was a heck of a lot going on. It was defined by clinician access, or lack of clinician availability, rather, access to our facilities or into patients' homes, et cetera, a huge amount of fear, and then sharply increasing patient acuity. I mean, all of these things combining at one time for us to try to just earn our way, to talk our way into the home, to do visits, sometimes in hospice in particular, through the window, many visits through the window. So we had the less access inhibited our control over visits. We had lower demand for therapy initially, and then we had excess availability, and then all of a sudden we had a huge amount of demand for therapy, and that changed it. That changed our ability to provide care. Nursing has been in high demand since March 1st, 2020 for us, and that has not relented, and we are. Here's my public service announcement for nurses looking to move out west. But we, like many of you out there, are really working to onboard new nurses and hire new folks, and that has to do actually with just growth, frankly. So really looking at that. And back to the subject, our census increased steadily, which I mentioned. So there certainly was likely a LUPA impact involved in that. But all this said, it was a super dynamic environment. Looking at a 4% haircut at a behavioral adjustment, it's not as if we woke up every day and said, well, you know what, we have to change our behavior so that we can make another X amount %, because we were focusing on everything that I just mentioned. But the concept in and of itself of a behavioral adjustment, again, this is just myself speaking, is inherently flawed. Now, PPS reform was needed. And I actually commend, hopefully this isn't controversial, but I commend CMS and MedPAC for taking a leap and for coming up with PDGM. None of us were going to be 100% happy with any new payment model. But doing so under the auspices of assumption that we would be changing our behavior, perhaps may have been the one thing that catalyzed us to change our behavior. And that may be me speaking less just about Evergreen, but you know, if you know you've got to walk 10 miles, you make sure you're prepared to walk 10 miles. If you know that you've got to make up 4% plus, or however, was it 7 at one point, then you're going to do it. So it was certainly a rough thing to swallow, a rough pill to swallow. But I think we all did it.
Great. So that leads to my last poll question here: is how has your LUPA percentage changed since Q2 of 2020? Has it increased, has it decreased, or has it stayed just about the same? A couple more questions here before we get to some Q&A. Molly, I'm going to skip down to a question here of, one of the pieces we talked about last week is give me some real world scenarios on how, LUPAs can really impact your agency, like a real life example of a patient and how, some of those challenges can be overcome, and how to a more of a real life scenario on how to really impact it.
Sure. Yeah. So this is one we were just talking about last week and bringing to our pod meetings and talking through. And, we do, like Laura mentioned, we talked about, when we talked about preventable LUPAs, it just kind of got like, what do you mean preventable? And I guess I could have done X, Y, Z. So we kind of even broke it down and we said, hey, was this moved for a non-clinical reason? Because that's pretty preventable. And that's kind of the direction we went from there. Plus, that kind of gets the, like, yeah, it was. And that you can kind of see where you're kind of taking the patient care out of it. We moved it for a myriad of reasons, if it's staffing or whatnot. So the scenario we had recently, and again, we bring this, we write it all up, we put it on a calendar and put dollar signs to it, how much, is we had a DC visit and it was planned for Tuesday, the end of the billing period, and it got moved to Wednesday. So we had a 5 and a 2 or 3 LUPA. So all of a sudden now we have a LUPA in the first, and now we have a LUPA in the second. So that one, and we moved a visit, I forget the exact scenario. I think it was, I don't know, it was for non-clinical reason, we moved this visit. And it ended up being about a $1,400 difference when we took all our costs out and things like that, you know, roughly. And so that's what we present. We say, hey, by moving this visit for whatever non-clinical reason it was, you know, and $1,400 can add up. We're doing that kind of all over the place. So that was the most recent one. And that really, it really speaks to, you know, like what they can impact, what we can look at, and what finally happens at the end with that.
Yeah, and I know there's been some questions on just kind of balancing out periods. That kind of is a good, almost a cautionary tale of, you know, if you're really trying to expand and get into that next period, sometimes you may, you know, if you think you're getting an extra payment by continuing on, that actually might, you know, backfire, I guess, in this scenario where your case where it ended up creating 2 LUPA payments rather than the full period payment.
Yeah, and the other thing to that, like, I know LUPAs are obviously financially driven in their finances, but really when we talk through it, it's like, it is a utilization metric. So we are talking about utilization. And so really working with the people who are managing the utilization, which are the clinicians, is just really, we can't lose sight of that. And when we hear clinicians, oh, that's money, that's all about money, that's where we're like, actually, that's where it ends up. However, it's a utilization metric. So really remembering that.
We talked a lot about transparency and education and really informing your clinicians. You know, specific for you all at Evergreen, Brent, maybe you want to handle this one. How do LUPAs and LUPA percentage, LUPA rates, do they factor into how you evaluate your teams or your pods or even your individual clinicians?
So the answer is yes. We share our LUPA rates directly with our pods. Molly, correct me if I'm wrong, but I don't know that we're able to actually share individual LUPA amounts with a clinician unless they're just associated with the case through their balanced scorecard.
So we pretty much bring it back to the pod level, knowing that it's kind of a pod or a team utilization. So we don't drill down that far.
Yeah. So thanks. The clinicians get a short version of a balanced scorecard. So we evaluate certain aspects of, you know, completeness of documentation, of course, productivity, LUPAs for the pod, et cetera. One thing I wanted to mention, which goes along the lines of transparency, and Nick, if you will, for just a sec, this concept of it's an organizational mentality, an organizational approach to the way that we do work. And maybe on one extreme you have this is how many visits you're going to do and do them and go for it. And then on the other extreme, it's we're going to arm you with information and we hope that you make the right decisions. I think we're probably further off to this edge, which is hire good folks. Obviously, we're all working hard to do that. Give them the information and have high expectations of them. Create standard work, and then in the lean vernacular, walk the floor, the Gemba. Make sure that we know what's happening out there, and make sure, most importantly, that there's trust from a clinician level all the way up to senior leadership, so they can say, "Listen, this is not smell right. This isn't working right. You need to know." So that's, in my mind, a very fundamental aspect of being transparent.
Great. And then one last question here before we get to some questions, you know, just kind of a quick wrap up in terms of any tips that you have regarding how to best measure. Give me some simplified tips that I can bullet out and give to our clients, and we'll bill you for it later and say there's our own thoughts. So I'll start with Molly and Brent, and then I'll go to Laura on that one. Part of that too I wanted to talk about is, you know, any tools that you have seen successful. You know, we talked about, I know one of our discussions we had last week was what tools are in your EMR, and if you don't have those tools in your EMR, some other thoughts on what to do instead. So Molly, I'll start with you on that one.
Yeah, I think the biggest thing is that that we've really relied on is that LUPA in progress. And so really supporting the clinicians in reminding or saying, I don't know if you have it in front of you, depending on what phase the EMR is in, but here's where it is and let's talk about it. I think that's a big one. And then, like I said before, remembering it's a utilization metric. And then our scorecards are sent, so they have those in front of them. That's another great tool that we have had.
Brent?
Great. Molly mentioned EMRs, guys. Your EMR should be working for you, and you should be working closely with your EMR, right? It's a bit of marriage, and you've got to put work in on both sides to make sure that works. And briefly, Molly mentioned earlier the business analyst. We have a position at Evergreen, which is actually someone that oversees our business, our data, and shares data. And he's working on multiple requests for me at this moment. He's working with Molly and the home health management team. What we did is a couple of years ago, we essentially made the decision that our group of managers, the managers essentially the size of a branch manager, each of them has about 250 to 300 patients and about 50 clinicians. And they, as a team, said, we don't want to add another person on. We'd rather be more efficient with our group and then add on this business analyst. So we hired a very talented individual named Alex Van Gundy, who's speaking at FMC. He has really allowed us to share data ubiquitously. So if, Nick, self-proclaimed data nerd, we have our own in-house data nerd and an excellent one. And he just does a great job spoon feeding this information to leaders so that they can lead and make decisions with the data.
Great. Laura, any tips on your side?
I'm just going to give just some quick basic tips. The block and tackling, is that a sports analogy? I'm not a sports person, but I think that's what it is. Starts with onboarding. If people understand why, it's easier to help manage them on something. Brent was right on the money. Use your EMR. Somewhere in there, every single EMR has some sort of report. It's called a variety of things, but find it. The other one to run is everybody has a missed visit report. And that one is key. And that doesn't mean running it once a week. That is a daily run, at least a 3 times a day run, or 3 times a day, 3 times a week run on it, and taking a look. Plan your care for 60 days so you understand what the spread of visits is going to be. That helps you get past that 230-day problem that you've got, and see very quickly if they go into one of those crazy observation stays where they have to stay on the hard bed and don't get actually admitted. So it changes things. You can plan around it. If you don't have something robust, there's a little thing called an Excel spreadsheet, and you can keep track of things there. So if your EMR isn't doing exactly what you want it to, you don't need to be a fancy analyst. I can come up with spreadsheets at that level, and you can always call in help, call in folks. I want to just hit one question. I see a lot of people asking for benchmarking data in the questions, and it is hard to get to. Home Healthline does a benchmark of the week every week in their thing that they put out. CMS does publish some things. Go to your state association. Oftentimes they'll have information for you. And certainly you can come to somebody like SimiTree. We have the ability to scrub through the claims data from Medicare, as well as through a financial monitor. We can trend and benchmark against things. So I know it's hard to find really good benchmarks. And then join conversations like this, because you've got a lot of benchmark data today, right?
Absolutely. Thanks, Laura. So I think we have about a minute for some Q&A. I'm glad you touched on the managing the first and second periods for LUPAs. I think that was some good advice there. That was a question that was at least referred to a few times within some of the Q&A pieces. Real quick on caseloads, that question came up. I thought is a good one, and it's something I think is always a benchmark that's out there. Molly, any thoughts on caseloads? How do you manage your caseloads? Do you have a benchmark for caseload for your clinical managers for ideal LUPA management?
So yes and no. So we were working through that, and we keep kind of a, there's a range of a caseload that we kind of work at, and we're going, sometimes it's 20 to 30, and it really depends. Does that clinician have a PTA support, LPN support, things like that? What is their, sometimes they have a ton of patients at one facility, or they have a lot of cath care. So yes, they have a lot of patients, but the actual frequency and acuity of those patients isn't very high. So we do have our range, but regardless of the range, we have to have a communication around and a plan around that range. Are they communicating to their manager, their scheduler, and they say, hey, I have to close my caseload and here's why. So we have our range, but it's honestly hand holding it when things get closed quite a bit.
Great. Laura, you see similar numbers?
Yeah, nationally, best practice across the country is 20 to 24 patients with a case manager. Can go a little higher if their acuity is lower. If patient acuity is lower, it might go a little lower if the acuity is high. And much like you said, Molly, giving them, you do need some built-in case management time for the actual case manager. They do have to do the coordination work and calling physicians and whatever. So they usually have a little bit lower productivity standard.
Excellent. Well, we are officially at the hour here, so I wanted to very much thank our wonderful panel. Made my job a lot easier. Great insights from the team over at Evergreen, Molly and Brent. Always a pleasure to have you on. Laura, this is the first of many of these that I'm sure we'll be doing together, so excited to have our first SimiTree webinar under our belts. And if anyone has any questions, you can go to our new website, which is the full website is still a work in progress, but SimiTreeHC.com. You can go there to contact us for any questions. If you have any questions for Brent or Molly, I can point you in their direction as well. For the folks that did ask questions in the chat, we have your contact information, so we'll be following up with some answers to some of your questions as well. I appreciate everybody being on as well. And again, look for the link coming out tomorrow with a recording for the webinar and also that one-page recap. Thanks, everybody.
Thank you.
Thank you. Happy Tuesday.